Good evening. My name is Stephen Hernandez, and I'm the Executive Director of the Legislature's Nonpartisan Commission on Women, Children, Seniors, Equity, and Opportunity. We are here tonight to continue what has been an ongoing series on the sexual abuse to prison pipeline. This is the third of a series that we have been collaborating with several of our partners, not the least of which is my co-host for the evening. Tonight, we're going to focus on disability and mental health. Sexual abuse can have a detrimental effect on a person's mental health. Experiencing sexual abuse during childhood is associated with a wide range of mental health disorders in adulthood, including anxiety, depression, PTSD, psychosis, antisocial personality disorder, suicidal ideation and behavior, substance abuse, and much more. It is critical to ensure that these health conditions are treated seriously so that survivors can access the treatments and supports that they need, while of course ensuring prevention at the onset. We'll be discussing how sexual abuse can affect a person's mental and physical health outcomes, and we'll specifically focus on the prevalence of sexual abuse among people with disabilities. A word of note for parents and guardians: this forum will address sensitive issues that may not be suitable for children without adult supervision. Viewer discretion is advised. As we go forward now, and without further ado, I would love to introduce my I like to call her my co-conspirator, but she is my co-host of Substance for tonight, Larice Harvey. Larice is one of the great eight, inducted into the Connecticut Hall of Change, memorializing her 20 plus years of restorative justice, public health, and racial justice modalities and policy changes. She is the co-founder of Once Incarcerated, offering peer support to youth and adults currently and formerly incarcerated. She is the author of Button's Journey, My First 2 Years Living with PTSD. I'm so proud to have you here again, Larice, and welcome you as you guide us through this important conversation. Welcome, Larice.
Oh, thank you, Steve. That's beautiful. Always a pleasure. Gratitude all around, because if it wasn't for you guys, I wouldn't have known the value of this conversation. I just knew it needed to be had. And when the report came out, Sexual Abuse to Prison Pipeline, the girl's story, and I was going through it, I was like, wait a minute, they forgot about us, those of us that are abused by our parents or a family member or a strong friend of the family that you're considered an aunt or uncle to family members. And I also thought about, they forgot about us who are getting raped in prison. And I was the one who led the charge on the PREA, Prison Rape Elimination Act in Connecticut. That was the first time I told about being raped in prison. And because of this series, I want to say I was honored with a Swan Award recognition, which recognizes survivors who are strong advocates. And I shared that award in recognition with the commission, Steve, you and Denise, because you guys took a risk. And we keeping it classy while educating, and you can't educate without understanding terms. And one person I know who solidifies and understands the terms of sexual disorders, and she's a strong advocate for those who have sexual disorders, and saying that in order for us to heal, we need to be informed. And as long as we're informed, we can heal. And I believe in that, because I understand why my parents did what they did. They have a mental health disorder, and that in itself helped me heal. And I talk about that in my book. So on our panel today, I'm going to introduce everybody real quick, but when you start going, you introduce yourself, and I want to hear all your credentials before you start presenting. So we're going to go in this order. We're going to have Cindy Preza from One Standard of Justice. She's going to give us our terminology and some background and educate us on some sexual disorder. Then we got the wonderful Deborah Dorfman from Disability Rights Connecticut. She's going to talk about disability rights. She's going to talk about sexual abuse, occurring with disabled people. And then we got our wonderful Annette Diaz from Amplified, who is also a board member of Once Incarcerated. And she's going to talk about how we can begin to heal and some coping mechanisms. And as always, Steve, we're going to close with our wonderful Calvin Young to do the healing. And then you're going to wrap it up and let us know what we're doing next, because the 9th is next week, and I don't think we're ready for our policy one. I think we might have to push it till the 28th or January. But I give it back to you, Steve, if you have any more comments, and then we could kick it over to Cindy.
Well, thank you for mentioning the last meeting of this series, which will really focus on our policy recommendations. We have been here together now for three conversations where we have highlighted some of the issues. We're getting the language better, or at least getting it right when we can. And we're offering recommendations to the legislature. This is a short season, so they begin their work in early February. So a January meeting to really button down our recommendations, I think, is most appropriate. And I just really, on behalf of the people of the state, want to thank you for all the work that you've done so far. So without anything further, Larice, I hand it back to you to introduce our first guest.
Our first guest is Cindy, and I am sharing her slides for right now. So Cindy, welcome. Introduce yourself to the world. Unmute yourself.
All right, so much to learn. Good afternoon. My name is Cindy Prizio. I am co-founder of One Standard of Justice, which works with persons accused or convicted of sexual offense to ensure that they are treated constitutionally and fairly before, during, and after their experience with the criminal legal system. We don't and never have advocated for crime. We advocate for people. And I recently called myself, after discussing with some people in the therapeutic community, a human advocate, because we must recognize there are two sides to the same coin. There are people who have been abused sexually, and there have been authors of the harm. And we can't treat one without the other. And real prevention will begin by treating the victim on both sides of this. So I want to thank Larice for encouraging me to get on this call. I just before I start that, and I want to thank Steve and Denise for inviting me on. This is sort of a unique situation for me. And my job here, in order to get ready for tonight, I had to go back and replay the recordings from the first two sessions. And one of the last things that Steve said at the end of last month's session was that he encouraged everyone to go back and listen to the recording again. And quite frankly, having put on webinars throughout 2021, I recognize there are so many messages to unpack that you can't possibly hear it and get it the first time around. So thank you, Steve. Good advice. I'm here to shine a light on some profound, complex, and meaningful information on paraphilic disorders, in particular, who perpetrates child sexual abuse. In full disclosure, I am not in the therapeutic community. I'm a former marketing executive. And right now I'm a lobbyist for my company, One Standard of Justice. I want to recommend to everyone that I will be dabbling in different concepts today. I'll be introducing hopefully some new stuff, and I welcome you to send me an email and I'll share all my data with you. Okay, next slide, please. So I have big shoes to fill. I listened to Nani's presentation and Richard's presentation, and I mean, there's not a word I heard that I disagreed with. Who perpetrates child sexual abuse? Well, in Nani's slide, she had, it was 7% strangers, and then family and acquaintances were 93%, and she broke it down. I did not break it down today for the purposes of this event, because it changes, quite frankly. The younger the child is, the more likely the person's being abused by a family member. And the older the child get, the more likely the person's being abused by an acquaintance. But basically the numbers are the same, and I rounded them up. What we didn't talk about in the first couple of webinars, and you may find this very surprising, but this is in old research, children who sexually abuse other children are found to do it at about 30 to 40% rate of all offenses. Now, what's surprising about that is children with other children, and the community, the therapeutic community, the research community thinks they've grossly underestimated that number. And we're looking at numbers as high as 70 to 80% right now. So we have a lot of work to do. And it reminds me about, we don't want to criminalize our children. That's all I'm going to say. We have a lot of work
Well
to do.
said, Cindy. Well said.
You can go to the next slide. Before I go into the pedophilic disorder, I want to talk about one of the questions that I think may have come up, or certainly we thought about. Children who are abused sexually, what is the likelihood that they will go on and sexually abuse other children? And it all has to do with, it's really not a predictor, but it is a risk factor. The more trauma and the more unhealed trauma, there is a risk. Again, it does not predict. So if there isn't necessarily, if I do this, I will go on. If this happened to me, I will go on and do this. And so, for example, we're going to talk a little bit about the adverse childhood experience, or the ACE score. But the more trauma in one's life, the more violence in one's young life, the risk increases to abuse other children. So all that means is we need to circle around our children who have been abused and give them protective factors. And an example of a protective factor would be that we offer the right level of treatment, not only for the child, but for his caregivers who are experiencing secondary trauma. So protective factors and risk factors are sort of common terminology, across different programs. Okay, so oops, go back one more, hun. Go back to the other slide about, okay. Larice asked me to start with this slide. I had them reversed a bit, but I think it makes perfect sense. There is so much confusion and manipulation around terminology and language. And one of the biggest words we have misrepresented is pedophile. And so I was asked to go into the Diagnostic and Statistical Manual, the DSM-5, to discuss the pedophilic disorder. And these three conditions, A, B, and C, must be in play for somebody to have the DSM diagnosis of pedophilic disorder. And so it has to do with extreme and intense thoughts. They're calling them intense, recurring, sexually arousing fantasies, sexual urges or behaviors involving sexual activities with a prepubescent child. And a prepubescent child is usually considered 11 to 14 years old. The individual has acted on these sexual urges, or the urges are making the person distressed. So that doesn't say that it's a must that the person has crossed the line and has acted on these. And then the individual has to be at least 16 years old, and 5 years older than the younger actor. If we could go on to the next slide, please. So not everyone who sexually offends against children has a diagnosis of pedophilia. And you may be surprised to know that there are people in our communities that identify themselves as a pedophile, but they may not even have a clinical diagnosis. It's just that what they identify with is strictly an attraction to a prepubescent child. It doesn't talk about acting on it. It's literally an attraction. And this community of pedophiles will not necessarily ever act on these urges. Instead, these pedophiles and others along the spectrum that are called minor attracted persons choose to lead law-abiding lives. Some of them are non-exclusive, which means they have relationships with adults. They get married and have their own families, but they still have this attraction that, again, they choose not to act on. So just as for repetition, not all with people with the DSM of pedophilia sexually offend. And not all persons who are attracted to minors qualify for a diagnosis of pedophilia. And not all persons who are attracted to minors offend. Oh, I see. Yeah. Okay. This is what you're talking about. So one of my jobs here was to talk about some of the disorders. And a pedophile just simply says a person has this attraction, and the age group is usually prepubescent. If I'm an infantophile, then I may have an attraction for 2 to 5 year olds. If I'm a hebephile, usually it's at the cusp of pubescence. So it's maybe 14 to 17 years old. And then a gerontophile has literally a younger person has an attraction for older persons. The reason this is important, because as a society, even the experts misuse the term pedophile. And there seems to be a mob mentality that anybody who is harmed or perpetrated child sexual abuse is a pedophile. And I'm just here to tell you, it's just not so. And so, I don't know what the numbers are, and I should.
No, that's okay. Keep it going. We're trying to do the language. We're trying to be all on the same page with language.
Well, minor attracted people, as an example, are born. We might have 10 born every 1,000 people.
Yeah.
So quite frankly, this is another thing, like parents love the one you've got. We don't control who our babies that we bring into this world are. And there seems to be a lot of confusion over gender identity and sexual orientation. And so I'm here to say, love the one you've got. People who author harm have often been victims of child sexual abuse themselves, but what they really are victims are of high ACE scores. And an ACE score is a questionnaire. I think there's 8 to 10 questions on it. So for example, did a parent or other adult in the household swear at you, insult you, put you down, or humiliate you? Act in a way that you were personally afraid? Did a parent or other adult in the household often push, grab, slap, or throw something at you? Did your parents suffer from a mental disorder, depression, substance abuse? And it goes on and on. And everyone
Right.
should take this, quite frankly, because it tells you that if you have an ACE score or 4 or higher, then you're in the high range. And so when we talk about this neurological brain development, and we hear often that, for a normal person with sort of average trauma, like nothing really that serious.
Hey, Cindy,
it
can
will
we
be
stay on
25
course, Cindy? Cindy, we got other speakers. Can we stay on course, please? Let's stay on course with your
Oh, I'm
slide.
talking about trauma though. Okay, well, my
Yeah,
point
you're
is
not
that,
on trauma. I talk about the trauma part. That's my part. That's me telling
all
my
right,
story.
all
I
right,
need you to
all
just
right.
go through your slides. Thank you.
Okay. The people who author harm and persons in our families who are under stress, who lack coping skills. Some of these could have comorbidity. So the person maybe has a substance abuse problem. Generational simply means that we pass it from generation to generation. So what was done to my mother by her family member, she's done to me. And then unless somebody breaks a cycle, I pass it on to somebody in my family and so on. Persons with substance abuse often perform child sexual abuse and don't even know it. So they can't even say whether they did it or not. Autistic persons, often they feel, we know that if you are a person with autism or on the spectrum, that your social cues are off or lacking. And so everybody just wants a little love in their life. And so they misinterpret these social cues. And often they are either predatory for sexual harm themselves, or they will sexually harm. And then, persons with intellectual or developmental disabilities, same thing, and persons with a diagnosis of pedophilia. But I have to tell you, there are 1 million people on the registry, and we probably have about 5% of them that have been clinically diagnosed as a pedophile. Okay, barriers to reducing sexual harm and mental health. Mandated reporters may surprise you that mandated reporters can actually block people from getting the help they need. So if I'm a person with minor attraction and I choose to lead a law-abiding life, but society's stigma hurts me, I am blocked from getting help because the mandated reporting laws are very strict or very subjective. And so you could think you're going for help and then you get reported to the police for a thought crime, not for acting. Society's got huge misconceptions. Why do we as a society say that victims can never recover from harm? If you ever read articles on this and then you go into the comment section, I'd like to think that, misguided, well-intentioned people will say, oh, this person can never recover from, and then you'll hear a victim say, I am a victim of violent rape and I did live through it and I'm glad I did. So society's
consequences, language like victim, perpetrator, family of author of harm.
That there's stigma placed on not only the person who was harmed as being a monster, but the person who has received the harm is getting a lot of stigma in terms of what a victim should be, behave, do.
Cindy, I want to thank you, but you ran over your time, girl.
All right.
You should have just stuck to your slide and we could have had more of a dialogue. But I do appreciate your input because it's very important and your message is very loud. It kept coming over and over again. We don't want to cause our youth harm. Youth are at a higher rate to who have been abused to abuse younger kids. And my experience, my parents from the ages 2 to 5 molested me. It was incest. And yes, there has been a lot of collateral damages. My mother continuously dated men who had these pedophilic tendencies. And one man she was with had 3 sons, and he would video us girls with his sons performing oral sex and having intercourse. And I was at the age of 8, and I kind of knew it was bad, but I thought it also was normal because I just came from that with my parents. And I grew up with this thing thinking that I was a pedophile because I did that to a 6-year-old when I was 8. And it wasn't until years later that, through therapy, that I understood that that was not so. And I found out in 2013, believe it or not, from my 81-year-old aunt, the great aunt, that the reason my father did that to me and my siblings is because he was taught that by his father, who was taught that by his father, going all the way back to slavery, talking about the cultural, generational passing on, because they wanted the girls, once they started getting their menstruation, to have a more loving, intimate experience before the master came and raped them. So this conversation is like, it touches so many bases. And part of me forgiving and healing was letting understanding that my parents have a mental illness. And from that point, I can support them getting help. And neither one of them are in prison. My father had to do extensive therapy, and my mom, she did her own process. And my sisters and I are healing in our own way, but we had to get the understanding of what it really was that they were suffering from in order for us to let go of the anger. And so I thank you so much for your presentation. Do we have any comments from the audience, Steve?
None that we're seeing now, Larice. We could probably continue the conversation, but I also want to appreciate the honing in on language, and the disambiguation of language is so critically important, because oftentimes in policymaking, we want to hone in on the right treatment, the right therapy, the right intervention, or the right response to what is actually happening. And oftentimes it is that disambiguation, that distinction, that's going to ensure that we do the right thing. So thanks so much, Cindy, and thank you, Larice.
Larice, unmute yourself.
I said, Cindy, thank you once again. You did an awesome job. Yeah, I could tell, it is like we have 3 presenters, and it is kind of like a short stand. So I be trying to get people to stay on task, but you did an awesome job. I appreciate you. Steve, would you like to introduce our next speaker? Deborah Dorfman.
Thank you so much. Thank you, Larice, for the opportunity. Next, we have Deborah Dorfman. We did introduce Deborah earlier as the Executive Director and Attorney of Disability Rights Connecticut, a friend of the Commission and someone that we look to often for the organization's disability rights legal advocacy. Deborah, throughout her career, has remained a passionate and committed advocate for individuals with disabilities. She has successfully participated in numerous class action and other systemic reform litigation for children with intellectual disabilities in the juvenile justice system, for individuals with co-occurring intellectual and mental illness inappropriately detained in state psychiatric hospitals, and for individuals with mental illnesses in forensic mental health facilities, jails, and prisons, and for individuals with IDD receiving community-based Medicaid services. Deborah, the work that you do is so critically important, and in a lot of ways, you are the last line of defense for our most defenseless. So welcome, Deborah.
Thank you so much. And thanks to Larice and to the whole commission for inviting me today to talk about this very, very important topic. And I'm going to focus my presentation on ending the idea of ending sexual abuse of people with disabilities. Just as a I know Larice asked that we talk a little bit about ourselves before we begin. And, I am the new executive director of Disability Rights Connecticut. I just began in February, but Disability Rights Connecticut is the protection and advocacy system for the state of Connecticut. We're a private nonprofit. This is my 4th protection and advocacy system that I've worked at, and I've worked at other private nonprofits throughout the United States representing people with disabilities. And one of the areas, of the many areas for which I've provided advocacy and legal representation is in the area of sexual abuse. I have represented both children and adults who have been sexually abused in a variety of contexts, whether it's in the community or in facilities. And so it's from that vantage point that I wanted to discuss the issue as it pertains to people who have in fact been victims of sexual abuse. And I am purposely using that word. And I think that it is the appropriate word in this context. So first, I want to give you a little overview of the presentation. Liz, could we just move to the next slide, please? Thank you. So what I'm going to cover today, and I realize I believe I have about 20 minutes, unless Larice corrects me. So wanted to go over today with you first a little bit about the prevalence of sexual abuse of people with disabilities, and then to spend some time talking about the barriers to advocacy for people with disabilities who've been sexually abused, and then talking about remediation of this abuse in the context of legal remedies, and then other types of remedies, and then talk a little bit about some resources. And then, obviously we have another speaker, and I don't know if there will be any questions, but anyways, maybe we could move on to the next slide and we can start talking about how pervasive the problem is. So what we do know is that people with disabilities, based on the professional literature, is that people with disabilities, and this is particularly true for women and girls, are abused at significantly higher rates than individuals who don't have disabilities. Although I have to say that there was a recent study that also found that individuals with disabilities who are men and boys also are sexually abused at higher rates than those who don't have disabilities. So it's not just women and girls, but I think that the rates based on data that is available do show at least based on the available data, higher rates. But it's important to understand that, before I move on to the point I was gonna make, I wanted to just give you some specifics around data so that you have a sense of this, which is that so the Bureau of Criminal Justice Statistics reported in a 2016 report for the period of 2009 to 2014 that based on data, reported data, that individuals with disabilities were 3 times more likely to be sexually abused and victims of violence than individuals who don't have disabilities. So it gives you some sense of the difference that we're talking about. It's quite significant. But it is really important to understand that while we have some data, the data isn't perfect, because unfortunately, this is an area where it's hard to get, I think, the full sense of the problem, because so much of this doesn't get reported. That's the reality of it. So much, and we're going to talk about why that is in just a moment, but so much doesn't get reported because of various different barriers to that, that I really, I think it's very good that we have the data that we have, but more data is really needed in order to be able to address the problem. But we do have some data. It's also important to note that the sexual abuse that happens, it happens in all types of contexts. It happens in the community. It happens in facilities, when people are incarcerated, when people are at psychiatric facilities, locked facilities, unlocked facilities, schools, in their own private homes. And so, oh, I'm sorry, if you could go back. Thanks. So, and also what is important to note is that there's quite a bit of sexual abuse that happens with respect to sex trafficking among people with disabilities, particularly people who have mental health or intellectual disabilities. And we'll talk about that a little bit here, because I think that that is important to talk about in the context of thinking about how pervasive the problem is. There, just to kind of also note the number of, there was a study done in Kentucky that found, and this was, back in 2013, but I think it's illustrative that of the, a report that was done found that of the minors who were being trafficked for sex, 71.4% of the minors in the study, and there were 161, were found to have mental health treatment needs. So that's a very high percentage, and it's not at all surprising. And we'll get to those reasons in just a moment, but I really wanted to point that out so that you can get a real flavor of how this really does affect people who have mental health disabilities and intellectual disabilities quite extensively. So I guess if we could go to the next slide, Larisse. Thank you. So now I wanted to address some of the reasons, like the barriers to the advocacy and why this is such a pervasive problem. And the first thing I think that's really important to understand is that so many people with disabilities, particularly people with mental health disabilities and intellectual disabilities, are isolated in one way or another. And isolation can happen whether you're in a facility or you're in the community. And it is very clear that sexual abuse is rampant in jails and prisons. It happens in like I was mentioning before, it happens in nursing facilities, it happens in locked psychiatric facilities, it happens in unlocked psychiatric facilities, it happens in schools, it happens in private homes, group homes. So it happens all over the place. And it's kind of this sort of hidden thing that people don't like to talk about. That's a problem. But when people with disabilities are isolated because they're either institutionalized or they're in the community and maybe they're with a care provider and they don't have interaction with their family or friends, or they're living on their own, there are a lot of opportunities for individuals to become victimized and be isolated and have no way of really reaching in a meaningful way out to others for help. So that is one of the things. And in fact, traffickers, for example, and abusers do like to keep people isolated because they want to keep people quiet. And they do that in a variety of ways, through threats, through promises, through a whole range of different things. So that's one key problem and why we see such a high rate. Another has to do with power inequities. And this is also really, really important to consider in all of this when you're thinking about, well, how do we address these problems? So part of it is, of course, with the isolation. So having people integrated and included as much as possible in the community helps, but also making sure that the power inequities don't create situations that allow for sexual abuse. So having oversight. And so what do I mean by power inequities? I think it's important to understand that too. So some are pretty obvious, like in a prison, you have the correction officers and the administration who run a prison or a jail, and then or juvenile justice facility, and then you have the person who is incarcerated, and that person is, really at the mercy of the person who is detaining them, because they have to abide by all the rules, or they're not going to eat. They're not going to be able to, have opportunities for socialization. They're not going to have opportunities to even take a shower or just sort of meet basic human needs unless they're allowed to really by the people who are detaining them. So there's a tremendous amount of power right there. And that type of thing can lead to situations where, and I'm not saying that everybody who is a correction officer does this by any means. I'm just saying, I'm giving an example of a power and equity that can lead to that kind of thing. The same is true for when somebody is in a locked psychiatric facility and the person isn't free to go. They're not free to call on the telephone necessarily. It depends on the situation, but there are a lot of different types of power inequities. The same thing happens in the community where you may have a person who lives even in their own home and has a care provider that comes and stays with them. And that care provider is really the person who the individual really relies on to be able to get food, to have personal needs met. And so there are, again, more power inequities that can develop, which can lead to things. And I'm going to give you a couple of examples.
Hey,
So that you
Deb,
can, yes?
Can you speak a little faster? We only got another 30 minutes to continue before we have to close.
Okay, so we'll just quickly go over here, and I can skip the examples at least for now, but other barriers are the lack of access to justice. So it's, very hard to get prosecutors to take these cases because of potential proof problems. It's also extremely difficult even to find a lawyer who would bring a civil action, because there aren't a lot of lawyers who have the experience to do it or really want to spend the resources and take the basically the litigation risks to bring these cases. So that is another problem. And then just the, often people who have disabilities are in poverty and don't have the resources to pay for a lawyer. And so there are access to justice problems. There are also problems with having accessible community-based services for victims. That's another issue. And then there is stigma and preconceived beliefs about people with disability, beliefs that they don't tell the truth, beliefs that they aren't able to articulate what happened to them, and basically sort of the idea that they lack veracity and so they won't be believed. Can we go to the next slide, Louise? So what are some legal protections for people with disabilities? And this is not just people with disabilities, but people who have been sexually abused. Well, for those who have been victims of trafficking, there are federal and state anti-trafficking laws. There's a federal Trafficking Victims Protection Act, most recently reauthorized in 2019, which provides both criminal and civil sanctions against individuals who traffic people. And there's also some funding under these acts for services for people who've been victims. There's also something called the Racketeer Influenced and Corrupt Organization Act, which also provides for civil and criminal penalties against individuals who engage in a pattern and basically in a planned sort of endeavor to traffic people for profit. There's also Title II of the Americans with Disabilities Act. That is important because that can help a person who may need accommodations in getting services in order to support them after being sexually abused. And it can also, the Olmstead provisions of the Americans with Disabilities Act of Title II, which really require that individuals not be unnecessarily segregated, can also be helpful because it promotes inclusion. And as I mentioned earlier, the opportunity to be included and be part of the community helps really kind of take the person out of isolation and lessen the risks of sexual abuse. There's also, as Larice mentioned earlier, the Prison Rape Elimination Act, which was enacted for the very purpose of protecting prisoners, not only people who are incarcerated in prison, but individuals who are in jail or juvenile justice facilities, and even in community, for example, probation or parole confinement they're also protected under this act. There's also a number of other legal claims that can be brought against abusers, civil legal claims, tort claims for harm that is suffered. And then there are, of course, other criminal sanctions that if a prosecutor is willing to bring them, an individual who does perpetrate abuse can be criminally sanctioned. So there is a whole range of options. And I wish we had some more time, and I would be happy to maybe in the future talk more in detail about what these laws, how they work. But in the interest of time, I'll move on to the next slide. There are also some administrative remedies. So, for example, if a person is a victim of trafficking, they can file a complaint with the United States Department of Justice. There are also often states have similar sort of administrative remedies and complaints that can be filed against traffickers. There is also what we have here in Connecticut. There's a council that addresses trafficking, and actually a group that is referred to as the Human Anti-Trafficking Response Team, and that is for children who have been victims of domestic trafficking. So that's another resource and option. We'll just move on to the next slide. So just a couple of resources, and there are many more resources than just this. And if people need more resources, they're free to call Disability Rights Connecticut, and we can provide more resources. But there is the National Sexual Assault Hotline. There's RAIN, which I gave you the website for. They can also connect folks with the National Sexual Assault Hotline. We also have one here in Connecticut. And there are a number of resources locally in Connecticut. And then, of course, Disability Rights Connecticut, because we at Disability Rights Connecticut, one of our core duties is to investigate and remediate abuse and neglect of people with disabilities. And that is, so sexual abuse is included in that. And so I've provided our phone number. We also have a video phone for people who may have hearing impairments. We can also be contacted through our online intake and through our website. So I will conclude for now, just in the interest of time, but thank you.
You are most welcome, Deb. Thank you, but I'm not done with you yet. I want to bring you back to your slide with these laws because, I'm trying to keep in the time frame we have. That's all. I just wanted to make sure we kept in the time frame. Now, going back to your laws page, Trafficking Victims Protection Act. Can you talk about that? Because that leads to a lot of women and men who are overly incarcerated for prostitution when really they're being trafficked.
That's right. That's right.
Mhm.
Yeah. So there's federal law and state laws, and Connecticut does have an anti-trafficking state law. The federal trafficking law provides a range of protections for those who are victims of sexual trafficking, also labor trafficking and other kinds of trafficking. But since we're talking about sexual abuse, and so some of the things that you can get through through the federal law includes, there's the opportunity, for federal criminal sanctions if the U.S. Attorney's Office decides to prosecute. But there's also causes of action. When I say that, I mean legal claims that people who are victims of trafficking can bring against the people who traffic them and get compensatory and punitive damages against them. So that's a civil action. Also tied to the federal protection is some funding for services for people who have been victims of trafficking. And then for those individuals who may not be, in the United States with documentation, and they've been trafficked, they've been brought to the United States, they've been trafficked, there's also an opportunity to get some help in terms of immigration issues and getting certain types of visas so that they can stay because they've been trafficked. And so that also relates to this legislation. And the trafficking, Congress often doesn't agree about a lot of things, but the good news is they keep on reauthorizing the Trafficking Victims Protection Act. And like I said, I think the most recent reauthorization was in 2019. And the idea is to keep expanding protections. Now, the states also have anti-trafficking laws. Actually, Connecticut has had one from, I believe, around 2006 or 7 or 8, sometime around then. And so that's good. I haven't been in Connecticut for very long, but what I can say about state anti-trafficking laws is that they're great to have, but they vary quite a bit throughout the states, and they often don't have as robust protections. And so one of the things, and I just want to go back to a point that you raised, Larice, about people who get prosecuted, and that's been a problem. That's a big problem under state law, is that you find a lot of people who have been trafficked end up being prosecuted because they've been trafficked. And that is a really big problem. So some of these state, and again, it really depends on the state where you're in, but some of these state anti-trafficking laws have, there has been an effort to try to address that problem through those laws. But, I have to also say that are we really seeing those state anti-trafficking laws really being implemented? Not so much. It's a problem, and it's something that I think is something to really focus on, because there are those protections, and also maybe looking at trying to get people protected, trying to go through the federal protection. I think is much stronger. I think another thing it's really important is to build a cadre of attorneys who can take these cases on, because even if prosecutors decide that they're not able to prosecute for any number of reasons, and they have prosecutorial discretion, and that's up to them, but if we can build a cadre of civil attorneys who can take these cases on, I think that will go a long way. There have been really significant damages awards against people who traffic. And so we shouldn't forget about those opportunities, and those damages can be really significant in, money isn't going to change everything, but money can be very important when you're trying to get your life back.
Exactly. I'm experiencing a lot of that stuff. So now I need everybody to come on screen, because we're going to dialogue, because Cindy comes from a different perspective than Deb comes from. And you heard a little bit of both sides. And so Cindy was talking about the ACE, right? Spectrum. Cindy, you're unmuted.
The adverse childhood experience, which probably 80% of people in prison have a high ACE score. And the importance of that is that while it doesn't justify their behavior, I think it gives them hope to understand why. It's like Richard said, it's not like, what's the problem with you, Larice? It's what happened to you, Larice.
Yeah.
And there's a project called the Compassionate Prison Project. And a white woman who she was like a child of the streets, substance abuse, traffic, whatever. She had a hard life. She decided as a documentarian to bring this into prisons. And it's just so heartfelt, because she'll say all these men in a circle, and she'll say, okay, out of 300 of you, who was raised by a single parent? And then you take a step forward. Whose father spent most of their lives in prison? And so you start understanding what happened to you as opposed to what you did.
Now, I need everybody unmuted and on screen, because we're about to get into this, because language is very important. You got legal terminology, and you got medical terminology, and then what Deb deals with is the combination of both. And I got my story, and my story is not unique, and then it is unique because it's uniquely mine, right? But it's like you said, majority, like 86% of the women that's incarcerated have some kind of sexual abuse. I believe that's what the report said. And so when you look at the high rise of over incarceration of women to 800% in a 20-year span, you're wondering where was the social service support in the community, you know?
Absolutely.
And what you're saying from your perspective, Cindy, which is very important, is those who cause the harm are victims themselves. And I see that as a thriver, because I'm not just a survivor, I'm a thriver. I see that, but I also understood that my parents would have never got help if there was no intervening of the system. And this happened in the 70s, which was dealt with differently than it is now. They did not incarcerate my parents. They gave my father a year of treatment in a facility. You understand? And then they released him and he was out in the program, which is what Deb is saying. We need more services as part of the outcome, not just incarceration. And you're saying the same thing. You're coming from it two different ways, but you're still saying the same thing. We're talking about human beings. Even those who are mentally disabled, like I have a mental health diagnosis. I have combat and complex PTSD. It's because of the sexual abuse and trauma growing up. And it was not the same abuser, but I repeatedly got abused, right? Every system failed to protect me, even my family that took me in. And my parents got support, but they didn't get consistent support. So my father, over the years, the last time he offended me, I was 11. But at 11, I kind of knew. And I told him, you can't do that no more. I'm too big. And he didn't understand what I was saying. And now looking back, I can see my father was struggling with what he was raised to do, to protect us. In his mind, he was protecting us from somebody taking it from us because he loved us. But to me, it was like, you're violating my body and personal space. And for years, I hated my dad and mom for years. And if we're going to talk about this honestly, we need to talk about the foundation of I'm a human being who's a victim, and my father's a human being who's a victim, and my mom is a human being who's a victim. They're my perpetrators, but somebody was theirs first. And if we can just understand that common ground of humanity, we can move forward into a healing space.
So,
I mean,
Larice,
can we talk about that for about 5 minutes, y'all, before we introduce Annette so she can give us some coping skills?
Can I interject something right here?
Yes.
If I had a little more time, one of the concepts I wanted to bring up is the complete, what do they call it? Complete mental health. And there's criteria for it. It's a thing. And it's for people who have been abused sexually as children. And the research says that 67% of those who are self-reporting and participating in the research are identifying as having complete mental health, which is defined as being happy, satisfied with life most days in the past month, having high levels of social and psychological well-being in the past month, and being free of mental illness, suicidal thoughts, and substance dependence. Now, the only reason I'm bringing this up, if a lot of us, and this is the systems, right, in place, that have this attitude, we can't even get out of our own way. Why do others decide the effects of our abuse? If we are able to work with this cohort, and this has been repeated time, old data and new data, that's up to 70% of people can identify as having complete mental health after child sexual abuse, then what aren't we doing to the people we need to reach? Right? Everyone deserves healing.
Well, I'm confused about what you're saying. Can somebody, Deb, can you explain what she's saying? The complete mental health? like the legal terminology of that? Are you saying like somebody who has a healthy overall mental health status, who has been sexually abused, why isn't that more predominantly perpetrated as opposed to those who say they still sick and suffering? Is
I'm
that what you're
saying
saying? I'm trying to
something worked
understand,
right,
seriously.
exactly. Something worked right for this 67% of the people. And it's this, the research has been replicated. So
Oh,
my
you're
point
saying the
is,
survivors who were, when they were younger, nothing happened, they just kept going forward, no bumps in the road?
well, no, they probably had interventions and treatment, but my point is, look at all the harm and suffering of the people with the untreated trauma.
Oh, yeah, yeah.
That's
yeah.
what, okay, so if this was successful with this cohort or multiple cohorts in different parts of the world, then why can't we do it here in Connecticut, quite frankly?
See, that's a policy discussion. That's next session, girl. I like that question, though. That's a policy question. That's something for all of us to ponder. If you are listening, watching, we need to consider that. If it was working and it has a high success rate, then why aren't we using that as a prevention methodology on the onset of whatever the symptoms are? If somebody discloses, somebody you kind of, when I do presentations to the youth for civic and justice advocacy training, I tell my story, and you'll be amazed how many boys, like at least half of the class will come up to me individually in the course of the training and tell me they are at home being abused. And people are like, why don't you report it? And I'll ask them first, do you want me to report it? And they say, no, how do I protect myself? Because I'm using my body to protect my siblings, my younger siblings. And I know that feeling. I did that for my sisters. So I'm like, I'm mandate reporter, social worker. That's what we supposed to do. But that would cause more harm to her and her family and her upbringing, or his family and his upbringing, than it would if I reported it and they come in and snatch and take everything away from her. That's the harm you're talking about. See, the way I do it, she calls me, I tell her how to protect herself. She gets a plan. It's like being a battered woman. You got to have a safe plan of escape. There is no, come get me out of this situation. Is a safe plan of escape. If there is no safe plan of escape, then you are doing more harm than you are good, snatching the kid up out of the situation, because you're leaving the other kids there too. And like, so that is a really good conversation. Send me some more information, because I want to make that part of the conversation in the policy one, because that is absolutely, a good, because I hate being called a victim or
And
survivor.
regarding the adverse childhood experience score, 8 questions, 4 or higher, you have a high score. You're 6 times greater likelihood of being raped. 7 times greater is the likelihood of alcoholism. Early childhood trauma, which doesn't necessarily have to be sexual abuse. It could be neglect.
Yeah, anything. It could be anything. Anything.
Yeah, it's a problem. So.
Okay. Well, I guess nobody else wanted to get in on the convo. So we're going to go ahead with Annette. And Annette, are you ready to introduce yourself and tell us about your wonderful coping skills? Everyone else, turn off your camera. And Annette, turn on your wonderful mic. And I will share my screen with you.
Okay. All right, so while you're getting the screen up, I'm just going to do my introduction. So
yes,
go right
ahead.
Thanks, Larice. Thanks, Commission. Thanks for having me. This is a really good dialogue. Thank you. So my name is Annette Diaz, and I am a recovery support specialist. I am also a recovery coach. I am a person in long-term recovery. I'm a person with lived experience. There's a couple different labels people may be familiar with up here. I also am on the board of Once Incarcerated. I am also a former coordinator of recovery support services for one of the largest behavioral health clinics in Connecticut. I was there for over 10 years. Currently, I am with Amplify, an organization, and we'll talk about that, as the mobility manager. And, I am also a mom, and switching careers as due to my child having some medical stuff that I needed to kind of find a different path. All right, so, oh, wow, this is, so Larissa, I'm gonna do the coping skills after
Okay,
this. Is that all right?
yep, that's fine.
Okay, all right.
Promote you, girl. Go ahead,
Well, I
promote your
just don't want to forget,
organization.
right?
Right.
So Amplify is through conversation and connection. Amplify helps communities assess their behavioral health needs, identify gaps in services, and develop their plans to advocate for the most effective resources available. Although the name Amplify is new, it stands on the shoulders of decades of experience. Amplify has built a depth of knowledge of behavioral health treatment and cares across the lifespan from childhood and other adults. Amplify guides people through the rapidly changing models of care toward those that will best fit their community's needs. I will say that Amplify used to be called the North Central Regional Mental Health Boards. It started in legislative, like way back in like 2007, 8 or something like that, maybe even younger. And it's always been a trusted voice to figure out listening to communities, listening to people in recovery, listening to families, what works, what doesn't work. When Cindy was talking about ACEs, I've heard this trend in trauma and generational trauma. And so it all blends in together. You can go on the next slide. All right, so our mission statement here. So we are to strengthen the ability of our region to assess needs, develop plans, and advocate for strategies and resources to advance healthy communities. Hi, Mama, you go to the next slide. So in Connecticut, that's the resources. So I'm going to stop there. So, I am a person with the experience of sexual abuse, sexual assault. It comes from generational. My biological father was a product of his issues, and his family got passed down to me and my family. And then, of course, I didn't know, so I went to substance abuse, and I have mental health conditions, right? So you asked earlier, Larissa, about the onset of mental health, and this is what happened, right? Is due to my experiences of not knowing how to deal with what was happening to me as a child, as a teenager, not knowing even how to open a conversation to my family about it. This is what I am now, 41 years old, constantly trying to heal from those experiences. And yes, all trauma related, multiple trauma diagnosis. One of the things for me, because I don't want to talk about like the nitty gritty, because it's just very
go ahead, we here.
Well,
it's okay. This is what Amplify does. So use it in that content of advocacy.
Yeah.
Right now, you're advocating for your right to have this space, because that's what I had to do to get here.
yes,
So go ahead and advocate. I'm all here for you.
So, one of the things that I've learned is due to the experiences I dealt with, I learned to be in society, but in a way where I didn't know how to have interpersonal relationships. So because of the abuse, everything was related to what can I get from this person or that person, using my body, using my sexuality. I didn't know how to be like this productive member of the society. A lot of guilt, a lot of shame, constantly, very defensive. So I wallowed in over 10, 15 years of substance abuse because I didn't know how to act. I will say that one of the things I've learned is that the trauma is so deep that there's so many things that I've pushed back, and I have to constantly be in therapy or constantly be in a supportive environment in order to not shame myself, in order to not fall back in behaviors, in order to stay clean, and in order to just provide strategies that, guess what, I'm a walking, living example of hope because I can get through this. Okay.
Right.
And you know, one of the things that led me to applying for Amplify is they're always looking for systems change. You know, we're in a environment where the conversations are different. We're actually talking about mental health prevention. You know,
Right.
there's always stigma, there's always language, but I mean, they take it on as far as like, how do we come together? Because at the end of the day, everything affects everything, you know? How do we be normal? I think someone said it like, instead of like, what was wrong with you? Like, what happened to you? You know?
Right, Cindy said that.
I love that, because exactly what happened to you, because the majority of people that go through these experiences, it's not something that they woke up in the morning and this is a choice that they made. This is an adverse reaction to a choice that was taken from them, right?
From me, right?
Yeah,
So
took a
what do
choice.
you do? Like you've been around for a long time, and what do you do to maintain, like, what kind of coping skills as a peer
Yeah.
support professional, as someone who's been in recovery, doing both the re-entry aspect through mental health dual diagnosed aspects, right? How do you manage and help people manage, you know, this, you know, dealing with their abuse, their trauma, you know, and what skills do you give them, you know, now and then? And which
So-
ones do you use? Like, I want to get on that
You
too.
want to get on the ones I use? So I would
Yeah.
definitely say, for me, you know, I've tried several things, right? I've honestly taken little bits and pieces of things. So like I used to do Narcotics Anonymous a lot, which is, you know, a 12-step group. One of the things that stuck with me was the self-inventory. They used to have this pamphlet called IP number 9, and you would do a self-reflection. Did I cause harm today? Did I help somebody today? Did I say something positive? Literally. So I took that on as something that I practice to this day. Meditation. I had a hard time incorporating it because for long amounts of time, because of the trauma and all the loudness of the events, because you feel it, right? And you get those flashbacks. But
Yep.
now, like, I need to meditate. Like, as soon as I get up in the morning, I need to, like, don't talk to me, nothing, because I need that time to reground myself, to go through the day because of the work that I do in advocacy. It's a constant, you know, frustration sometimes. So that's one thing. Meditation, that definitely, they call it DBT skills, was something I've learned over the years, which is the
What is DBT skills? What is DBT?
Dialectical behavioral therapy. It's a concept, right? One of those evidence-based models out there that.
What is that? What do you do?
So it started in Hartford Hospital from a woman named Marsha Lenningham. And so what it is it's teaching you radical acceptance, it's teaching you emotional regulation, it's teaching you mindfulness. Let me tell you, best remedy ever. So that, and I learned a lot of that self-soothing skills. Like, basically, it's like slowing down your mind, slowing down your life, and being in the moment, in the present. It's a whole technique. It takes time, but it's so worth it. That was one of the things that worked for me. It was introduced for me when I was, you know, in Connecticut Valley Hospital. Another thing that works for me was peer support. So that peer support, because of my mental health, you know, and in the 12-step communities wasn't 100% fit for me because of some of the, you know, I consider myself in the critique of the persistently mentally ill because of my bipolar diagnosis. So, you know, I may not be viewed, or the issues I'm going through at that time, it just didn't mesh well. So peer support actually worked. And then what I mean by peer support is like those support groups, right? Not IOP, not clinical.
Right.
Services. Like somewhere where I got in and I was like, oh my goodness, I just spent $300 today and I didn't pay my bills, and no, I didn't get high. I was manic. Oh, and where you can walk in, they'd be like, oh, you're not alone. I did that a week ago, but this is how I managed, or this is how I got out of it. You know, like who would have thought, go back to the store and return it, you know, like something as simple as that. But sometimes the mental health symptoms, like I use the term, I drown myself in a cup of water because I can't get out of it. Okay. So that's one of my coping skills. Over the years, as life has gotten busy, one of the things I've learned, and I'm 100% honest with, and I always tell people to be honest with, is that some of the coping skills that I learned years ago are not working right now. So I had to step
Oh,
my game.
right.
I had to
Right, you
step my-
gotta, it changes as you get healthier, your coping skills need to get healthier. So
Yeah.
I'm gonna share the screen so you can talk about the resources. And then we're gonna chime in over to Steve so he can introduce Calvin, and then we can close this
Yep.
session out.
Okay. So I made these real general resources, right? So in case in Connecticut, oh,
Hold
there's
on.
Cindy again.
It don't skip, it didn't start at the right thing, it went
That's okay. We'll get
ahead.
there. All
Okay,
right.
there you go.
All right. So in Connecticut, there's a statewide network of sexual assault programs, and you could be reached by using the phone number. I put the English and the Spanish phone number. Okay, it's free, confidential. It's a crisis line. It includes 24-hour hotline. That means you can call 2, 3 o'clock in the morning, and they let you know that they're trained counselors. So go to the next slide. Oh, and they have the TTY access. So for people
Right,
who are
if you're
people who are hearing impaired, you can also utilize that resource. Go to the next one. So this one, and I don't know, I just left it general, and Larice can share the slides with you guys, so make it a lot easier to understand. So like Connecticut Alliance to End Sexual Assault Violence, their website, everything now because of COVID is internet-based, right, and web-based. So you want to go on there, see which ones are in the towns that you live in, okay? So there's the National Sexual Violence Resource Center, there's the online resource Center on Violence Against Women, and then there's the Rape, Abuse, and Incest National Network. Okay, so these are common resources.
That was the RAND
available.
that Deb was talking about.
Yep. So, and then these actually have hyperlinks as well for you to click on. So like sexual assault hotlines, if you click on it, it goes right to 211, because inside 211's platform has different phone numbers, times, hours, businesses run different, okay? But there's sexual assault counseling, there's sexual assault prevention, there's sexual assault incest support groups, and then there's the crime victim support. So again, if 211, it brings you straight in that resource. Go ahead, you go to the next one. So these are my favorite. So now my favorite stuff is peer support, obviously. So these are the peer support resources towards what we're talking about, okay? So there's peer support online, AART, which is an abuse, rape, domestic violence, aid, and rescue center. You can go on here. The website is devoted to providing information, resources for survivors and their families. So here's the peer support resources, where peer support's definition is one person has been through the same thing as you have been through. And then there's another peer support resource, which is abuse survivors. There's a Yahoo group, which Yahoo group started probably before Google got really into everything. But this
or
group,
Facebook.
yeah, or Facebook, right? So, and these groups are really, really helpful. You can go to the next one. And then here, look, After Silence, another, and this is Spanish and in English, peer support, A Long Walk Home. So, and I found out the majority of these are not like, so obviously these are run by people who have went through the experience and started like their own nonprofit organization and grabbed a couple other allies and support so that they can continue to teach and support people to be living with this stuff in the community. And The Silence, A Gift from Within. I love that name. Okay, you can go to the next one. So then they have male support, because this happens in male communities as well, right? So you have a male survivor. Here's the link. It tells you it's a support and resources for men who were sexually victimized as children, adolescents, and adults. So there's Male Survivors Trust. There's the Bisilican Project.
Yeah, we had Richard on here last time.
Oh, perfect. There you go. There you go. Go ahead. You can go to the next slide. So again, these are specific towards groups of individuals, right? So there's veterans as well. So I wanted to throw out some resources for veterans. So there's the peer support, military service members and veterans make the connection group, look, sexual trauma. And there's My Duty, and there's self-help room. So, because I didn't want to make, there was a lot more resources, but I know I was told I had a little bit of time. So I wanted to throw out like the meat and the potatoes and some golden nuggets so that you guys can kind of look further into it. But I know Larice can share this, but I wanted to say that, so I wanted to share with you the coping skills. I hope you guys got that, and it works different for everybody. Keep that in mind. And as I will be honest and raw, as you get older, you may need to switch your
You
game
need to
up and you
switch
may
them
need to
up.
find other resources.
Yeah.
So
You
that's all I
do.
have.
Well, thank you very much. Can everybody put on their screen and turn on their mics, and can we have a group conversation before we get mellow? I do want to thank everybody for, I mean, this session was a difficult one. I noticed Steve dipped out because he didn't want the commission too much a part of this. But it's okay, Steve. I got your back. I kept it classy as promised. My story is unique, and Annette's story, like I said, is not unique because Annette just said the same cultural thing happened to her as me. And so, like I said, mine is not unique, but it is unique because it's uniquely my own. And coping skills, that's important to let people know. As you grow older, sometimes those old coping skills don't work. And let me tell you, when I was in my darkness, my sister took me to her NA meetings, and we did that pamphlet in the 12-step book of NA, the spiritual principles ones.
Yeah.
And that is how you guys see me here today. It brought me back. It gave me my mind back. I had to reconstruct myself. I had to get rid of old beliefs. I had to stop blaming myself for what people did to me. I ain't do
And
nothing.
it teaches you the part that
Yeah.
you play it and things. Yeah.
I recommend that for anybody who got any trauma. Do that book. I don't know what's the name.
So that
of
book is called the 12-step Narcotics Anonymous Workbook Guide. That is a workbook.
guide.
You can get it online. Yeah.
Use it.
So,
I still
It's not
practice it
just
to
for
this day.
NA. I'm a living testimony. It is not just for NA. I mean,
No.
any struggle you're going through, it'll help you with the process, no matter
I
what
mean,
trauma you're
Some
dealing
people
with.
in NA might not agree with it, but thank God for multiple pathways.
Well, you know, we
So
gotta
I
help
just wanted
everybody.
to interject, if I may, especially since Annette talked about, I think, something, or was in her slide, something to do with artwork. Do you know what the Japanese art kintsugi is? Kintsugi?
I
No, I
don't
do
know.
not.
Well, I had a restorative justice conference where 2 doctors came in that were sexual abuse survivors, and then ones that weren't. And one of the exercises we did is we went to the dollar store and we took a bowl and we broke the heck out of it, small pieces, large pieces. And then the art project is that you make it another work of beauty. And that's what we see ourselves as. It's like pre-abuse, then abuse, and then we come through it. We see ourselves where it's part of us, but it doesn't consume us, and we are another beautiful piece of art. And I think
Thank
all
you,
these
Cindy.
symbolisms.
That's
Thank
another
you.
pathway.
I wasn't cutting you off. I was like excited. Like, yeah, that's a nice symbolism. Thank you. Wasn't cutting you off. I'm trying to pass it to Steve because we're running out of time. I'm trying to be respectful. It's
No,
5:26.
I'm glad I got to say that, because that's the stigma. We can all
Yeah,
get through most things together.
yes.
Mm,
I'll
thank
tell you,
you.
Larice, thank you so much to each and every one of you. It's so appropriate that right before we go into our own healing moment with the assistance of Calvin Young, that we ended with Annette's resources. And of course, with Cindy's beautiful imagery about taking those broken pieces and creating something beautiful from them. And Larice, to your point earlier, you know, you are at home here in the commission, and we are so grateful for this and the other difficult conversations that you have helped us navigate so skillfully and with so much empathy. You know, oftentimes, and you know, just as this is our home, so many of our viewers understand that these difficult dynamics may be happening in their own homes, and they may be happening silently, or they may be happening in a way that families are willing and able to cope with them and to work through them and to create something beautiful out of those pieces. So I want to thank each and every one of you, Deborah, Cindy, Annette, and of course, Larice, for your skillful management of this conversation today. And before we close, I want to turn to Kelvin Young. Kelvin, you are just such a gift to us. You're a community health worker at Intercommunity Healthcare and a certified sound healer. You are no longer a stranger to this commission or to the people of Connecticut, because You have joined us now several times. I turn the mic over to you now for your guidance.
Thank you so much, Steve, for this opportunity once again to be with all of you. Larice, great to see you as always. My colleague, Annette, Cindy, Deborah, thank you so much. Denise, thank y'all so much again for this opportunity to be here. Again, my name is Kelvin Young, and I'm a certified sound healer, which have opportunities to bring these different coping mechanisms or coping tools that can help us to deal with a lot of the emotional distress or even addictive states that we experience in our lives. And before I get into the sound healing session, I'd just like to share a few tools that Annette shared, which I thought was very, very helpful and beneficial to share. But one of the things that really helped me is sound healing, which y'all about to experience in a couple of minutes. And sound healing, where I use the different sound frequencies and tones from different Himalayan singing bowls or gong or crystal singing bowls. And the vibration really penetrates to the cellular level. My friend Nikki Meyer, she's the founder of Yoga and 12-Step Recovery. She often says that our issues live in our tissues. And I find that to be so, so true. The trauma that we experience in our life, those emotions that we suppress or repress, it's in our bodies, it's in our muscles, it's in our tissues. Our cells have memory, and our body keeps score of all of our experiences that we go through in our lives. So the sounds and vibrations and tones from sound healing, it penetrates to the cellular level and helps to release some of that stuck energy or stagnant emotion or trauma that's in our bodies. And oftentimes that trauma is released in the form of tears, which is a very beautiful thing, particularly in a culture that we're taught to suppress our emotion and suppress our tears. When we're able to release those intense emotions or trauma in the form of tears, it is a very beautiful thing. Also, music. Music is very powerful, very therapeutic. There's always a song, a melody, a beat that can connect to any raw human emotion that we feel within our hearts, whether it's grief, sadness, despair, love, peace, and happiness, or any other raw human emotion in between. You know, like Annette was saying, therapy. There's so many different modalities of therapy that we can utilize to help to address some of the traumas that we experience in our life. And I love Dr. Gabriel Marte. He mentions how trauma is not necessarily what happened to you. Trauma is what happened inside of you, the way you see yourself, the world, and the people in it from that traumatic event. So having a therapist that specializes in doing this inner work, doing the somatic work, because I believe that talk therapy could take you to so far. But that trauma, like I said, it's in our bodies, it's in our tissues. So different practices like EMDR or CBT or DBT are great practices that we can utilize. In nature, I think nature is one of the most underutilized antidepressants out there. Just going for a walk, going for a jog, going for a hike, just spending quality time in the beauty of nature. It has the capability to bring us to a place of balance and inner peace and stillness. So those are a few tools that I utilize and I encourage people to utilize when we're dealing with different types of emotional distress or addictive states. I failed to mention that I'm also a person that's in long-term recovery from alcohol and other drugs. And for many years, I used alcohol, marijuana, cocaine, heroin to deal. That was my coping mechanism. But today, I have healthier tools and healthier practices to help me to address the stress, help me to address the tension and anxiety that I deal with in my life. And I'm so grateful for that today. So at this moment, I invite you to get into a comfortable position as we end this session with a sound healing meditation.
If you want to participate, please leave on your screen. I hope everybody can see all of us participating. If you don't, you can turn off your screen and
That's right.
participate alone in private, but I leave mine on because I like them to see. This is part of my healing process.
There you go. Yes. We know what the green hair, the green hair means. That heart chakra, baby. You already know. So I invite you now to either close your eyes or bring a soft gaze to the floor or keep your eyes open, whatever feels most comfortable and safe for you. I invite you to do so at this moment as we take this opportunity to simply just be. And as we take this time to relieve stress find inner peace and balance through the transformative powers of sound. I now invite each and every one of you to take a nice deep breath in and a long breath out. We'll do this 2 more times. Take a nice deep breath in and a long breath out. One more time. Take a nice deep breath in and a long breath out. And at this time, I invite you to bring your focus, your attention, and your awareness to the sound you hear in the comfort of your space. And if your mind happened to drift away to, that infamous to-do list, or all those text messages and emails you need to respond to, or any other stressors or responsibilities that we have in our life, I invite you to gently bring your focus, your attention, and your awareness back to the sounds. Allow the sounds to be your anchor into the present moment. Allow it to be a gentle reminder to each and every one of us that the only time that we truly have on this journey that we call life is now. Thank you so much, everyone. Thank you again for this opportunity, Larice, Steve, and Denise, for being here and sharing something that really helped me on my healing journey to this day. So thank you again. Thank you.
Kelvin, thank you so much. And again, thank you to my co-chair of Substance, Larice, for guiding our conversation today. Thank you, Kelvin,
Thank you,
for
Steve.
closing us out in such an empathic way. Be on the lookout for the next and final part of our series, the Sexual Abuse to Prison Pipeline, which will be scheduled by Larice and company in the next few weeks, where we will be talking about concrete recommendations for our legislature based on much of what we have heard over the past 3 conversations. Again, I want to thank each and every one of our participants. As we said in the beginning, these are difficult conversations, and they're difficult because always at the root of them is us trying to help prevent and help address victimization of the most vulnerable, but also the mental health concerns that so many of our people are experiencing in the state of Connecticut. When you do both with humanity, compassion, and empathy, we get much further along. So again, thank you all so much and have a wonderful evening.
Thank you, Steve.